see it
presenter.
record. I see it.
Yeah.
I see it record button.
We are set.
Hey everyone, this is Ahmed Farag. I'm one of the R3s at the University of Kentucky. The Communications Committee puts on the webinars for anyone who has an interesting topic or wants to hold a webinar. Today, we're going to let the MSc organizer, Sidhan Thukral, is going to introduce our speaker. So we'll let you go ahead.
Thanks, Ahmed. Just real quickly, I wanted to say thank you to everyone who's here and taking the time to listen to this amazing webinar that we have in store for us. Couldn't really be possible without the help of obviously Ahmed, Tommy, who works with Ahmed as well in setting this up, as well as Chase and Rayon from the MSc, who really helped me turn this thought into reality, and I believe they're present in the audience, so I'm glad they were able to join us as well. Without much further ado, I'd like to introduce Dr. V, who has this amazing talk set out for us, Clinician, not Technician, History and Future of VIR. I just wanted to say before anything else is if you have any troubles unmuting your mic, or if you have any questions, you should all have my email or phone number by this point, so please just text me or send me an email and I'll try to get your thoughts out. Thank you, and I'll leave it to Dr. V.
All right, well, thanks for the kind introduction. I'm gonna get started. So I'm gonna talk about kind of where, kind of the history of interventional radiology and really the future as we look forward to where it's going. So it's kind of a clinician, not technician. What's the history of IR and what's the future of IR? And I'm one of the faculty physicians at Kaiser, Permanente in Los Angeles Medical Center. And so, okay, let's go ahead. So we have to start back in 1953 when this gentleman, the Swedish radiologist Sven Ivar Seldinger, figured out a way, and he published in Acta Radiology in 1953, this way of entering the blood vessel with a hollow needle and then advancing a wire, and through that advancing a catheter to take pictures of the blood vessels throughout the body. Before that, you had to cut down onto the artery to get catheters in, but this was a way to do it percutaneously without making an incision or cutting onto the artery or vein. So this is, again, a kind of a landmark event. It's called the Seldinger technique, and it's a way we do a lot of procedures, from aneurysm repairs to chest tubes to gastrostomy tubes, is using this commonly utilized technique, central lines, etc. So Seldinger, and he was a kind of a Swedish radiologist. But really the field began because of this gentleman, Charles Theodor Dotter. He's really the father of vascular and all of interventional medicine from head to toe, from the brain to the heart to the toes. He was the youngest academic chair of radiology, and he was truly a visionary. He developed the concepts of stents and thrombolysis, where you inject medication to clean out clot. But really, his vision started in June of 1963 when he was invited by Joseph Roche to the Czechoslovakia Radiologic Congress in Prague. And this was his talk, Cardiac Catheterization and Angiographic Techniques of the Future. So at one point when he was an angiographer, which is where you take pictures of the blood vessels throughout the human body. So that's what he did using Seldinger technique, but no intervention was done. One day he had inadvertently had to cross an iliac artery occlusion to do a renal angiogram or pictures of the renal artery. And so again, at that point, he had said that the angiographic catheter can be more than a tool for passive means for diagnostics observation. When used with imagination, it can become an important surgical instrument. So this was the first discussion of surgery without a scalpel. So again, this was a proof of concept. It was a theory in his mind. He thought it could happen. But the world of medicine changed in January 16, 1964, when Dotter had this patient, Laura Shaw, who's 82 years of age and absolutely refused amputation, but every surgeon said there's nothing you could do. She would rather die than have an amputation. So Dotter was sought out at the Oregon Health Science Center in Portland, Oregon, and was like, is there anything you do? And he took this wire and these Teflon dilators and was able to open up her superficial femoral artery blockage. And she was able to live a couple more years with both her legs. She ultimately died of heart failure, but she lived able to walk with her own 2 feet. And again, he's the original critical limb or CLI fighter, and he's kind of the father of all of interventional medicine. And it started in January 16, 1964. Subsequent to that, again, he was asked to take pictures of blood vessels and angiograms. But even at that time, they were like, "Hey, look at them, but don't fix them." But being the maverick that he was, he would do what he felt was right for the patient, and he was able to open up the blockages in these patients and prevent them from surgery and prevent them from limb loss. At that time, that same gentleman, Joseph Roche, who had invited Charles Daughter to Czechoslovakia to give that talk, was invited by Daughter to come to Portland, Oregon to work at the Oregon Health Sciences Center. This is Fred Keller, this is Joseph Roche, and Charles Daughter, all kind of great minds, kind of the originators of some of the originators of the field. And during the time that Roche was there, he had done a lot of great things, including building tips, but he did one of the first embolization procedures in the country or in the world. And this was a cirrhotic who had a upper GI bleed that he was able to embolize with autologous clot and infusion of epinephrine. So really, when you look at interventional radiology, especially the vascular bed, there's two things we think of. We either open circulation, which is blockages in the heart and the brain, whether it be strokes or blood clots in the lungs called pulmonary embolus, blood clots in the legs, DVT, open up blockages of atherosclerosis or hardening of the arteries in the legs or the kidneys or intestinal arteries. Or we block vessels, whether we block them to stop bleeding, whether it be like hemoptysis from the bronchial arteries or hematemesis from intestinal arteries, or even aneurysms that can bleed and cause subarachnoid bleeding in the brain. We can actually coil those vessels off, or in traumas, whether it be blunt or penetrating, car accidents or gunshot or knife wounds, where we can take solid organ injuries, what used to have exploratory laparotomy, we can fix with the little catheter wire and tiny coils. And the whole world of interventional oncology, where we're able to kill tumors, whether it be the liver, kidney, or the bone. So this is Cesar Jian Turco. He was also one of the interventional radiology physicians who was, again, a great inventor, innovator, who developed this coil that you could put into the human body. And before that, we were taking blood clot and autologous blood clot and using it to embolize, but he developed a mechanical device to block circulation to bleeding vessels. This is Guglielmi, and this is Fernando Vinuelo and Gary Duckweiler, some UCLA interventional radiologists, and they developed this coil called the Guglielmi coil, which is a detachable coil. So you get the catheter in there and you let it form, and then only if you're happy with it can you release it. Okay. So again, this was the first coil was used in a carotid cavernous fistula in 1990 at UCLA. So this is, again, an innovation that really kind of transformed medicine, where majority of intracranial aneurysms can be repaired with the either artery incision, the radial artery or the femoral artery, and you don't have to crack the skull open to fix these. Now, interventional oncology, many of you may have heard of, is kind of what we feel is one of the fourth pillars in cancer care, with surgery or surgical oncology, medical oncology, where they give chemotherapy, radiation therapy, and kind of what we do, either transarterial or ablative therapy. And in fact, one of the first transarterial embolizations for HCC was performed as early as 1978 by Professor Yamada. Now let's look at kind of the opening of circulation, and this gentleman was an important figure in figuring out how to do coronary angiography. This is Mason Soanes. He's a pediatric cardiologist at the Cleveland Clinic, and when they were doing an aortogram, the catheter inadvertently fell into coronary, so they accidentally did the first coronary angiogram. Now, as Daughter was at the Oregon Health Science, there was a gentleman, a cardiovascular surgeon named Albert Starr of the Starr-Edwards valve. And so Albert Starr was starting to do these complex valvular surgeries, and he needed someone at their facility to learn how to do cardiac coronary catheterization. So this gentleman was Daughter's first fellow, Melvin Judkins, actually went to Cleveland Clinic and trained under Mason Soanes, and they became very good friends. And in fact, what Melvin Judkins did is he figured out a way to make these catheters differently. So the way Soanes did it, he did it from a brachial cut down, Melvin Judkins, as an IR doctor, figured out how to do it from the femoral artery, and he formed these catheters, which are still used to this day, the Judkins right, Judkins left, and the pigtail catheter to do coronary angiography. And in fact, they developed the equivalents of SIR together, which is a SCI, the Society of Cardiovascular Angiographers and Interventionalists. And Mason Sones was the president, and Judkins was the president-elect back in 1978. Now, the collaboration, the innovation continued at a very rapid phase. So at that time, the concept of maybe we could not just take pictures of coronary arteries, but maybe we can actually also fix them. And so Andreas Grunts was an angiologist, and he went and visited a daughter at a RSNA meeting, and her daughter talked about this kind of balloon or kind of percutaneous transluminal angioplasty. And he embraced that. A lot of the American doctors didn't embrace it, but the Europeans did. And so Seitler and who's a German radiologist started to propagate it, the daughter technique in Europe. And then Grunts also kind of was adapting this model as well. And then he actually, in the 1977, dilated the coronary artery with a balloon catheter that he developed, called the Grunts balloon catheter. So Andreas Grunts was one of the first interventionalists to do kind of coronary angioplasty in 1977. So again, you can see the tremendous amount of innovation, rapid evolution of our specialties. Now, one of the things when you're opening up a plaque in the artery, you're taking this blockage and you're cracking it with this balloon. Well, it's a very disruptive thing. You tear the intima, it can cause platelet aggregation, it can recoil, it can dissect, and then complete occlusion. So it was very scary when they did it at the time, because if you dissected the coronary artery or vessel, you had to go to open surgery. Well, this gentleman, Julio Palmas, was an interventional radiologist and did this initially work at UC Davis, and then later UT San Antonio developed this, what's called the Palmas stent or balloon expandable stent. It was a metal stent that you were able to deploy and open up the vessel so that there wasn't recoil, and even if dissection, you could tack up the flap. And so it allowed for better patencies and prevented even more surgeries from happening. So he's now well known for his Palmas vineyards in the Napa Valley. So another great inventor, and again, part of the history, who unfortunately recently passed away, is Curt Amplatz. And Curt Amplatz was, again, a great innovator and really built the whole concept of endourology, which is where we can take out stones from the kidney collecting system, put in nephrostomy tubes, put in double J's, and do all these kind of percutaneous interventions. But on top of that, he was a kind of complex congenital heart interventionalist as well. And he developed this whole concept of the ASD and VSD occluders using this kind of metal mesh, going through these congenital heart holes that kids have and fixing them in a percutaneous fashion without open heart surgery. He developed a slew of other things that are too numerous to mention, but the Amplatz snare, Amplatz wires, to name a few of the multitude of things that he had invented. Well, innovation doesn't just occur in IR, but it works in collaboration with IR. So Juan Parodi was a vascular surgeon who worked with Claudia Schoenholz, who's an interventional radiologist who's now at MUSC in South Carolina, and Julio Palmas, who I talked about previously, who they jointly did this first kind of endovascular aneurysm repair in the Western Hemisphere in 1990 in Argentina. And this is a tube graft. So it was kind of a proof of concept in Juan Parodi's first patient. But having said that, a third-year medical student about 4 years earlier to that sent a patent for an aortic graft. So probably someone in the audience is thinking of something, and maybe you can have a patent. Maybe you can be the new innovators, and I hope certainly that'll be the case. Now, this innovation continues. I mean, I've talked about Daughter, talked about Amplatz and Jian Turco, and then this is Dr. LaBerge and Katzen and Dake and Benenati. And so many kind of like heroes in our specialty have made so much transformation in medicine. Melvin Judkins, like I said, Joseph Roche, who I showed you the GI bleeding, where he was the first to find a way to embolize the circulation. Grunts, who I talked about. This is Colapinto, kind of developed the first TIPS procedure. Julio Palmas, who I talked about, making the balloon expandable stent, etc. So again, this innovation just runs rampant in our specialty, and that's one of the exciting things about our field, is so many toys and tools to fix people's problems. These are kind of directional atherectomy, rotational atherectomy, things to extract product, lasers to open up circulation, different types of covered stents that we can use for aneurysms or ruptured vessels that are different companies have developed with different morphologies. There's transcatheter tumor work. We can get particles in, whether it be radiation beads or drug-eluting beads or bland beads or chemotherapy into the tumor very selectively. We can burn tumors without making an incision percutaneously using ultrasound or CAT scan or MRI guidance. We can freeze tumors in the kidney and elsewhere using cryoablation. So these are just a few of the thousands of innovations that are occurring kind of on a routine basis. Now, one of the transitions, so when we historically started, we were really kind of angiographers, meaning we just took pictures and we diagnosed. Daughter changed that. So it took radiologists from a picture taking and diagnosing role, invasive picture taking though it may be, to a therapeutic role. So in 1964, Daughter really changed the face of medicine, but he also changed the face of how radiologists acted and performed. Now, that was still those invasive, they weren't really taking comprehensive full care of the patient. And that really changed, I think, when this gentleman, Dr. Barry Katzen, came into the picture, and he's the founder of the Miami Cardiac and Vascular Institute. And he established a clinical practice both in Alexandria, Virginia, which is still very aggressive and progressive clinical practice, but he also founded the Miami Cardiac and Vascular Institute. And he was starting doing EVARs and aneurysm repairs as early as 1994. He was one of the first gentlemen to do renal angioplasty in the US and one of the early people to do TIPS in the US. And he really is a visionary. And I've learned a lot from talking to him and reading what he's written. And I encourage all of you to read about Barry Katzen's work and what he's accomplished and what he's done. And he's definitely someone to emulate. The model that he's established there is something that you should emulate wherever you go. And wherever you train, you should try to see if that model is existent. He started doing the ISET, which is an International Society of Interventional Radiology, doing live cases so he could educate the rest of the world on novel endovascular therapies. And there's a publication that he has in the JACR, Journal of American College of Radiology, Interventional Radiology, Transformation to Clinical Discipline. This is in the early 2000s, he published this. With him, he recruited this gentleman, Dr. Michael Dake. And Michael Dake was initially at Harvard for undergrad, then he was a medicine resident, and then chief resident of medicine at Baylor in Houston. And then he went to UCSF to do pulmonary critical care. After that, he actually did a diagnostic radiology residency, and then a UCSF interventional radiology fellowship. And then subsequent to that, he joined Barry Katzen at the Miami Cardiac and Vascular Institute. And he then later left there and went to Stanford and became the chief of that section. And he was the father of thoracic aortic interventions in the sense that he developed a stent and put a covered graft on it, PTFE graft on it, and deployed it in the treatment of acute aortic dissections and descending thoracic aortic aneurysm. So kind of thoracic aortic disease was, and the endovascular revolution was started by an interventional radiologist, Michael Dake. And this is actually Barry Katzen here on the far left, Michael Dake on the far right at the Miami Cardiac and Vascular Institute. So very exciting how the collaboration and the amongst the specialties and amongst the interventional radiologists was so key to innovation occurring and these transformations occurring as well. Now, this is one of my mentors who trained me at UCLA. The reason I came to Los Angeles was for him, because I realized at the time, at least, there weren't that many clinical interventional programs. So I really wanted to go train under a true clinician. And he saw 30 patients in the office a week, and it's something I've always kind of tried to emulate. And he did his own wound care. He admitted his own patients to his own service. And again, a very important concept that you want to be able to admit your own patients to your service and really learn from them and take care of them comprehensively. And so kind of our own practice at Kaiser was based on kind of the McNamara and Katzen model, so I was lucky enough to see that in live action and living color, and also be able to be kind of mentored from afar by Barry Katzen. Now, there is a very famous quote. I think it's important for you to understand where kind of things were kind of changing and why it's important to kind of embrace this kind of future of what IR is, or current and future of IR, which is really being a strong clinician. And he said, and this is something you'll hear over and over again. If my fellow angiographers prove unwilling or unable to accept or secure for their patients the clinical responsibilities attendant on transluminal angioplasty, they will become high-priced plumbers facing forfeiture of territorial rights based solely on imaging equipment others can obtain and skills still others can learn. And this is said about 4 years after he did the first angioplasty at the American College of Surgery meeting in 1968. So I think you have to pay heed to that. Again, these are visionaries, Katzen and the daughters of the world. So you need to kind of listen to everything they say. Now, I was lucky enough to view this PowerPoint presentation from Barry Katzen on IR and IO, and in it he had this slide, which is from Eamon Hobbs, who is the director or the founder of Angiodynamics, which is a big interventional radiology company. And basically what it showed is that, you know, we're really good at innovating. We generate an idea, we develop it, but then there was a certain lifespan, and unfortunately certain procedures were migrating out, so-called lost procedures, and then we had a certain residual. And really it came down to two things. One is like we weren't kind of getting the referrals from primary care or urgent care or ED, and we were relying on specialists to kind of manage these patients. And so we didn't have a good foundation of knowledge of disease. We were good at the anatomy and pathology. We weren't good at the physiology or pharmacology or managing patients in the office or counseling them on how to take care of these patients in a conservative fashion. So I think that was an important lesson learned. And so kind of historically, the patients would come from the primary care to a vascular surgeon or surgeon and then to IR. And he felt, Eamon Hobbs, is like it should really be a predecessor surgery, kind of like how GI or cardiologists first see the patient, then it goes to a surgical group if they're unable to manage it. And so I think in the same way, since we're the minimally invasive specialists, that's really the way we should drive therapy, is really the least invasive and most effective therapy should be offered to patients. And if we have a safe, efficacious, and durable procedure, then that should be the one that's given to patients as a primary opportunity. So I was lucky enough to hear this daughter lecture by this gentleman, Andreas Adam, who is with the British Society of Interventional Radiology chair, and he was also a daughter lecturer, so he was a distinguished person, and he gave the 22nd annual daughter lecture, and it was like this Veni Vidi vanished. And basically what he said is, hey, and are we fishing from the wrong pond? Meaning there's the people who are diagnosticians, whether it be radiologists, pathologists, then there's IRs who are more like surgeons or like interventional cardiologists or GI doctors who do procedures, who are really more about that component of patient care and not so much about the diagnosis. They want to evaluate and manage and counsel patients and treat patients. And so that really kind of caught my eye and caught my attention and made me really rethink, like, is this a problem that we have? The other thing that he said in his slide deck and his presentation at the daughter lecture was, our training is not suitable to becoming a good clinician or good clinical IR. We're spending too much time and those of your radiology residents will know this phlegmatic thing, and those of you going to be going into radiology will learn it as well. But we're spending a lot of time in these kind of rare disorders, not spending enough time on angioplasty or stents or microbiology or pharmacology or physio, which is really what's going to help our patients in the long run. So it was kind of an eye-opening thing for me to realize, like, we have to not only change recruitment, but also training. So again, recruitment and training are the key, okay? And so we developed, and I urge you guys and gals to go to this website, the rfs.sirweb.org, and on it you'll have a lot of resources that we spend a lot of time and effort to develop. And this is something that I and Ken Lamb and Deepak Sudender, we kind of jointly developed, which is the resident fellow section. We fought hard for free med student membership. We fought hard for this to become to generate our own web page. We fought hard for a lot of things. So it's really important that you guys all take this advantage of this resources that we generated. But really our goal was to be the voice for you as trainees, whether you be medical students or residents, okay? And we wanted to really focus on the clinical model of interventional training, okay? Meaning focusing on patient-centered care, becoming disease experts, and continue to expand this knowledge base. And we want to continue to change the training model. And we want to recruit the best and brightest like-minded trainees who really believe in that message of clinical medicine patient care. So one of these things, and I know we've talked about it in Siddhant, and many of you have talked to, is this concept of dedicated IR interest group. Because initially, if we're really going to listen to what Andreas Adam said, is like, hey, we're fishing from the wrong pool. Well, we got to expand our role from the diagnostic radiology pool to the surgical pool, because this is really minimally invasive medicine or minimally invasive surgical field. And we want to focus on people who really want to take care of people, who care about people, who want to take care about them as their primary goal, want to spend their primary time in the hospital or in clinic seeing patients or talking to patients and counseling them, as opposed to just diagnosing processes more like radiology or pathology. And really, also, you have to really have a true passion for working with your hands and improving your technique, kind of like someone who's a sportsman, or sports, someone in sports. The ideal athletes are always trying to improve their technique, and this is something you have to be passionate about to do this well. And also, you have to have the stamina. You have to develop endurance like an athlete. Like you can't play an 82 game NBA season if you're not training for that. So you have to develop stamina and the kind of lifestyle demands of being a busy athlete or busy VIR practice. So again, it's fundamentally different than golf or something like that. It's an endurance sport of sorts that you need to be kind of ready for, and it's a technical skill set that you have to develop. So you have to keep on working on your technique, whether it be the 3-point shot or the free throw. It's like that 10,000 hour rule. So that's an important concept as well. But ultimately, it all starts with you really want to take care of people. So let's look at the knowledge of disease and look at the different specialties. So if you look at radiology, the focus in why radiology is so important is because you learn anatomy and pathology from head to toe. There's no more efficient way to learn head to toe anatomy and pathology than radiology. But as an interventional radiologist or vascular interventional physician, you have to not only learn that, but you have to learn physiology, echocardiograms, PFTs, ABGs, EKGs, right heart cath pressures, if you're dealing with PE, pharmacology, management of diabetes, hypertension, role of statins, antiplatelets, and anticoagulants are all important to get the best outcome for your patients. So if you just put a stent in and don't do those things, your patient's going to have a poor outcome. And that's important. Or if you drain this diverticular abscess, but you don't put them on appropriate antibiotics, they're going to recur and they're going to end up with an ostomy. So your results are going to be reliant on your understanding of these other things. So again, radiology is the most efficient way to learn head-to-toe anatomy because it's hard to learn all the anatomy of the brain, the head and neck, the chest, the legs, all that stuff. The way to learn the anatomy and pathology most efficiently is radiology, and radiologists are very good diagnosticians and can, in diagnostic ultrasound and CT and MR, become kind of the current model of how to find out what's going on, okay? So I think it's an important skill set you need to develop in those first few years, But it does lack important features of physical exam, history taking, admitting a patient to your service, managing ill patients with cardiopulmonary, renal, and liver disease, managing diabetes and hypertension, and most importantly, also counseling patients, because my primary role is a guidance counselor. I'm guiding them through these difficult paths. I have to help them make decisions, and they're not easy decisions. So use science to help you, but you still have to know what the patient wants and help them decide what to do. All right. So one of the key things that happened was interventional radiology in the US became a primary specialty in 2012, on September 11th. So it became the 37th medical specialty, okay? It became from subspecialty to primary specialty, kind of like the equivalent of internal medicine or pediatrics or et cetera, or dental surgery. So it became its own specialty, and that was really important because it enabled us to change training and recruit students who wanted to take care of patients directly. And I think that was really important paradigm shift, okay? So the last 2 or 3 years, we've seen that where the fundamental difference in the trainees is now we're identifying people who are more surgical minded, who really want to take care of patients, who are passionate about interventional medicine and are willing to work hard to take care of their patients the right way. Now, a few things that you have to do in the integrated residency is you have to embrace the clinical component. And what does that mean? Well, you should do formal inpatient consults. You should admit your patients to your service. Okay, so you learn how to manage the disease and the postoperative issues. You should have an outpatient clinic with longitudinal care, meaning you should follow these patients for a long period of time, if not lifelong. Okay. Now, there's so many things that we're able to do these days, right? We're able to pull out clot, right? And there's 2015, there was 5 randomized trials showing the safety and efficacy and the benefit in taking a person from lack of functional independence to functional independence have increased by 40%. So dramatic improvement by doing intra-arterial stroke therapy. Okay, this is a patient who couldn't walk because he had a basilar artery thrombus. We removed the clot and he was able to walk. Fibroid therapy, again, can replace hysterectomy and myomectomy in a lot of patients with a small incision with more rapid recovery and reasonable durability and very good efficacy of 90%. We're able to fix thoracoabdominal aneurysms now with endografts, so putting holes in the grafts and modifying them, we're able to repair these complex aortic diseases. This is a patient of Karthik and mine that we treated. She was in her 40s with Berger's, and she had been smoking, and you could see this gangrenous digits here and kind of was starting to demarcate. So this is a few years ago. This is my first kind of pedal plantar loop. We dilated it up. She was able to not get a below-knee amputation. She had a TMA, and now she's become so grateful that she's become one of the big kind of proponents of stopping smoking in the Berger Society. So again, the impact that we have is so great on these patients. So patients fight hard, we have to train and fight harder. So this is another patient who had a meningeal resection, had a filter placed, and then for about 2 weeks he had developed a clot and he couldn't walk for those 2 weeks. So he was transferred in, and we used this device called the Angioback, and we were able to put this large sheath and do veno-veno bypass and pull out all this thrombus. And within 24 hours, he was no longer on IV pain meds and was able to walk. This is a patient of mine who has Takayasu's, who's had carotid vein bypass with stenoses and kept on reblocking, and she gets kind of global hyperperfusion and a little bit of almost altered mental status, and because her circulation's not so well. And so we were able to did this with my neuro-IR colleagues. We put a occlusion balloon here, dilated this from a brachial approach, and you can see the marked improvement in perfusion at the top compared to the bottom. So again, kind of working from head to toe throughout the human body. So how do you optimize your training? Many of your third years, but some of your first years and second years, some of your fourth years, some of your residents. Well, let's look at kind of the first years of medical school. So you probably are aware now how important microbiology is in the COVID crisis and COVID issues. So it's important to learn pharmacology, the medications that we're utilizing. It may not be as important for radiology, but it's certainly important for IRs, okay? Because we're working throughout the human body and different pharmacological adjuncts, whether it be chemotherapy, antibiotics, etc. Microbiology is obviously very important because we in interventional radiology are very heavily involved in the various infections, whether it be diverticulitis, appendicitis, cholecystitis, cholangitis, urologic urinary infections, etc. So you need to be able to manage these patients' necrotising pancreatitis with superinfection, so on and so forth. So you should understand the microbiologic milieu, diabetic foot wounds, etc. Anatomy, obviously, and pathology, because in radiology you need to have that very strong foundation. As a surgeon or interventionalist or proceduralist, you need to have a very strong foundation in anatomy. And pathology, because you just want to know what you're dealing with and natural history of that disease. And then, like I said, physiology is going to be very important, whether it be hemodynamics. And any of you who are kind of fourth years or interns, et cetera, you can understand the importance of physiology, especially when you're dealing with ventilators and kind of all that pulmonary physiology and cardiophysiology comes to be very important, including renal. So the things that I tell trainees to really learn well is cardiophysiology, pulmonary physiology, renal physiology, and hepatic physiology. All right, and neurology is becoming more and more important because of our increasing role in stroke therapy. And I think step one is a good way to kind of put it all together, all the organs together, and consolidate that foundational knowledge. So I encourage kind of first and second years to kind of look forward to that in a fashion to put it all together and get a good kind of base. So when you go to third year, you're ready to kind of use that in a more clinical setting. So what about third year? What are kind of the important things that you should be taking out of third year as a medical student? Really kind of general surgery, both anatomy and the surgical techniques, and also kind of the day-to-day existence, because that's going to reflect kind of the interventional, this kind of day-to-day existence, kind of rounding, pre-rounding, cases, clinic, etc. Internal medicine. So you want to get a good foundation in history and physical exam. Again, really get your cardiology, GI, nephrology, infectious disease, oncology, and pulmonary down during that internal medicine block. Okay, OB-GYN, obstetrics and gynecology, because we're going to see a lot of overlap, whether it be fibroids, tubal ovarian abscesses, and different cancers, whether it be cervical or uterine or ovarian. So you really want to get these foundations down in third year medical school, and then neurology for stroke and neuro exams, so you get that really honed down as well. Now, fourth year is part of the 7-year training program in interventional radiology, in my opinion. So it has to be your first clinical year, okay? Because you don't have as many clinical years as some other doctors, so you need to make sure that you use that fourth year to your advantage, so you've got a good foundation for your intern year, okay? So you want to get some busy IR sub internships, and those who are kind of applying, you want to get some letters out of those sub internships. It's a busy program, and I say it's a C cubed, right? So you want to have a combination of clinic, consults, and catheters. I see a lot of people just going into the office, or not going to the clinic, or not doing consults, just kind of being in the scrubbed in cases and assist. Well, you're not going to learn as much. You want to be an equal member to your junior residents over there. Okay. ICU is another important rotation. Try to do a month of ICU, MICU, SICU, TICU, whatever is busy and high yield at your program. Okay, vascular surgery is a great block in the sense it's a surgical field, and you also get a lot of catheter time and endovascular skills and learn about that disease process well. Cardiology consults and stroke neurology and surgical sub-IR are some additional things to think about to add on to your fourth year curriculum. So again, really you want to get some good busy sub-Is and IR with a mix of consults, clinic, and catheter time, ICU, and then vascular surgery, and then those other ones are pretty high yield as well. Okay. During your surgical internship, and Ahmed can talk about, he's done a lot of work on this to make it such that we identify programs that are highest yield for those going into interventional. So again, you don't want to just be kind of doing floor work the whole time. You want to be spending time in the outpatient clinic seeing patients. You want to be doing consults from the ED or the floor, but you also obviously want to get good at the postoperative care and recognizing postoperative complications, whether it be postoperative bleeding or leaks or sepsis or what have you. And you also want to spend some time in the ICU. Not all surgical internships have ICU, but I would look into that and try to identify programs that do offer that. And then you want to be in the OR as well doing cases. So some people get 100 cases sometimes in a year, which is great in the OR. And if you can get a vascular surgery month or two, that's again a great added benefit. And you get some more endovascular time as well in that. And then try to get comfortable with managing wounds, because I've seen that's something that's lacking in doctors in general. Now, how do you continue to integrate it? Again, so this is training, right? So we talked about recruitment, let's talk about training. So we talked about the importance of fourth year and getting all those kind of blocks in. But as far as training goes, current model is actually a little bit falling behind. It's only 3 months the first 3 years of residency, all right? So that's actually a step back from the UVA model, where they integrated a lot more IR and clinical rotations those first three years. So in fact, we kind of borrowed the UVA model, which also Michigan's borrowed and Russia's borrowed as well. And what we did was we have our residents, their second year of residency, PGY2, doing ICU nights and weekends. So they're still maintaining their unit experience. And I think of all the clinical rotations, ICU during residency is the most powerful, and you can see how valuable it is in this kind of COVID era. And then we also have them do call and IR, and then a couple months of IR back to back. So then by that end of that second year, they get pretty comfortable. All right. So third year, again, you still want to, third and fourth year, you still want to maintain, you want to do at least 2 months of interventional. So I call it the 2-2-2-10. So 2 months of IR the second, third, and fourth year, and 10 months the fifth year, and then a full on the final year, the sixth year. So not 1-1-1, that's too much gap, too much time. So in the 13 4-week blocks, you want to have at least 2 IR months and arguably some intensive care training as well, or clinical training. So we do a month of CCU, kind of our PGY 3 year. So anyway, these are the things that you should be thinking about. Okay, and then PGY 5 year, PGY 4 is mostly studying for boards, and then PGY 5, again, more intensive care training, a month of vascular surgery, 3 months of neuro IR, because you want to get comfortable with stroke therapy and all the catheters, wires, and coils, and liquid embolics that they use in the brain. It has a lot of overlap with what you do in the periphery, so you want to get comfortable with that for treatment of visceral aneurysms, stroke, thrombectomy. You can use it in the legs and elsewhere, etc. So again, these are invaluable techniques that you want to get. And then final year is kind of a mix of IR and neuro IR. Now, so integrating the IR and clinical rotation, especially ICU, is super important. Okay, and our trainees get about 4 to 5 months of ICU, and they get about 6 months the first 3 years of IR training, or 6 or 7 months. So you want to get adequate training, right? So, doing 1 month a year, you lose your clinical skills, you don't generate the technical skills that you want. And so you're not getting that clinical integration that's really required to really kind of, move forward rapidly and kind of be an advanced practitioner by the tail end of your training. Now, the clinic is another important thing. This is where you learn, again, to be a doctor. You learn how to talk to patients. You learn what's important, what's not. You learn what you do well and what you don't do well. And so our residents have a half-day clinic a week throughout their PGY 2 through 6 training. And so I encourage you to kind of look at there's several programs that have already instituted this, IU, I think USF, UVA, a slew of programs that have this kind of continuity clinic developed. And so I encourage you to, wherever you go or wherever you look, try to make sure that's a part of your training. Or if they don't have it, make sure they're looking to develop it. Okay, I think it's an important thing for your career. All right, so it should be a continuity clinic. And one of the things that we have our trainees do, I think is important, is to give talks to get their own patients. So it's important to develop your own patients that you're following, that you're their doctor, even during your residency. You shouldn't wait to be an attending to do that. This should be during your residency where you develop kind of that, you're overseeing patients' care. And you want to comprehensively manage the patients, meaning watch their A1Cs, look at their microalbuminuria, watch their blood pressure. You want to screen them. If they need a vaccine, a flu vax, you should get it so they prevent the mortality. Smoking cessation, etc. And a colorectal and mammography screening. It's your patient. You should take care of them like they're your family. Okay. Follow these patients longitudinally. Many of these patients we follow for life. It's extremely rewarding, and you're their patient. The patient sees you as their doctor, and they become like family. So this is Barry Katzen on the right, who I talked about. This is Jim Benenati, who's the program director of the Miami Cardiac and Vascular Institute training program. And what he says is consulting directly with patients and their families is highly rewarding. When you know the patient, when you know the family, and when you develop rapport with them, the highs that you get from those great cases are so much higher than you could ever imagine, he says. If you want to be happy 25 years after you go into practice and love what you do every single day, then develop a clinical practice, and you'll see that your rewards will be 10 times greater. And I agree. I think developing those relationships with patients is so important for your preventing burnout, for job satisfaction. Patients are very appreciative, but if you got to show that you care. You should care for them like they're your family or friends. And I think if you do that, clinic is much more rewarding. Cases are more rewarding. You're going to fight harder to have a good result. So again, formal consultation service is something you should really look for, and certainly longitudinal follow-up. And you should also look at how many patients are being admitted to the IR service. Okay, that gives you an idea where they are in kind of the clinical realm. Now, as far as service lines, this is another important concept that I think is really something that I learned kind of from the kind of leaders of SIR. And successful practices, you build every service line in your division, right? You don't focus only on one, right? So I see a lot of places they focus on just cancer and venous work and not much else, right? So they'll do ablations and TACEs and biopsies, but you need to also, get your training in neuro work, okay? Stroke therapy, like I said, it's a huge big deal now, right? Carotid disease, aneurysms of the brain, ABMs, vascular disease with peripheral arterial disease and critical limb ischemia. There's 10 million patients with peripheral arterial disease, and a lot of patients who are undergoing amputation without being seen by a vascular specialist. So this is where you can help them out, especially the underserved populations, okay? Those are the ones who need the most help. All right, aneurysms, venous disease, like we talked about, whether it be superficial veins or deep venous thrombosis of the legs or pulmonary embolus to the heart and lungs, placement of filters and removal of filters are all part of the vascular service line. Putting in shunts into the liver to decompress the liver for variceal bleeding or ascites called the TIPS, or blocking gastric variceal bleeds or big balloons in the stomach called BERTO. All these things are part of the kind of the vascular line. We do a lot of GI, GU, and reproductive things. Like I said, treatment of fibroids, treatment of benign prostatic hyperplasia where people have struggled to pee at night or get blocked up or peeing frequently. We can help them out by blocking the arteries to the prostate and shrinking them and improving their symptoms dramatically. These are all relatively new things, but dramatic impact on patients' quality of life, okay? Fertility therapies for women called tubal recanalization, where we open up the fallopian tubes, or block the varicoceles in males to improve their chance of fertility. And again, we treat appendicitis, pancreatitis, diverticulitis, cholecystitis, cholangitis. So all those are patients that we will see in our practice. Pain is a huge spectrum of therapy, including musculoskeletal interventions, whether it be vertebral augmentation, putting cement into the back to fix a compression fracture, or burning the nerves or to relieve pain. Dialysis is a huge vulnerable population that we also manage, whether it be making fistulas nowadays or fixing fistulas or putting in catheters or putting in peritoneal catheters as well. So again, what do you look for in training as you go through this kind of milieu? Figure out, how do I get trained well so I can come out ready to take care of patients comprehensively? Well, you want to be able to have an admitting service where you admit to your own patients and look at the number of admissions they're doing. That'll give you some guide, okay? And everything should be a formal consult. There should be no order for invasive procedures. It's not an x-ray. So if they're still doing this, where they're ordering invasive procedures, then I'd be a little weary. I think this should be a consult by this day and age, okay? And then you really want to go to a place that has longitudinal comprehensive clinic, where you're following patients longitudinally, often for life. Again, this is where you learn what you do well, and more importantly, what you don't do well, okay? And you're going to manage comorbid conditions, and you're going to be able to offer conservative management for these patients, which is really, really important to do. And again, you want to build all service lines, not just cancer and veins, but stroke, get trained in it, PAD, perhaps aortic disease, DVT, PE, pain, musculoskeletal interventions, so on and so forth. So when you're truly integrating training, I personally believe a surgical internship with a lot of operative time, clinic, like I said, consults, ICU, vascular surgery block, surg-onc block, acute care is invaluable, all right? During the second to fourth year, those first 3 years, which is mostly radiology driven, you still need to have at least 2 months of IR each year. You want to get some ICU integration because right now, that 1 month your PGY 5 year is too little too late. You know, I encourage you guys to do it as an MS4, but you should all do it during your PGY 2 through 4 year. And this resident continuity clinic is invaluable for your training. So I think our specialty has a very bright future when done right. Okay, it's becoming a surgical type field. It's very busy given the scope and complexity of our practice. And really, I do think that the old model of a pure procedurist will be harder to justify, as it just will be kind of viewed as itinerant surgery and patient abandonment, and will just be seen as wrong. VIR will continue to transform medicine rapidly. I think that's going to continue to be the case. The innovation is going to continue to happen at breakneck speed. It's going to be hard to keep up with all the transformations that are occurring. And I do think that someone here in this audience is going to be the next Charles Daughter, Michael Dake, Barry Katzen, Curt Amplatz, Jean LaBerge, Julio Palmas. One of you will be the next kind of visionary and who will change the field of medicine forever. So that's pretty much it. That kind of is a rapid fire through the history of, like, the brief history of interventional and where I kind of see the future of interventional. So I'm going to kind of open it up to questions. Hello?
Is anybody having any trouble unmuting?
Do you have any, let's see here.
Remember, there's also a questions tab that you can enter in if you can't talk.
Or if you guys have questions, you can Ed or Siddhant if you want to ask. I think they're unable to unmute too. So let me see if I can, give me 1 second here, let me see. All right, I'm muted. Jacob?
Hey, I just wanted to say thank you for a great lecture. I didn't have a question.
Oh, that's awesome. All right, thanks.
Dr. V, can I ask a question? Something that I hear frequently. When's a good time?
Hold on,
Yeah,
there's
sure.
one question. Let me just answer this real quick. With the breadth of procedures available, how will we balance performing the wide breadth? Do you see subspecialty and IR coming? It's a really good question. So I would say that it already occurs to some extent, in the sense that as it gets more and more complex, you will have some subdivisions of that occur. So even in our group, like a couple of us do most of the complex aortic work. 2 or 3 of us do the more complex kind of CL critical limb ischemia work. And so I think that's all part of the process. But yeah, but at the same time, if I have a patient with like varicose veins or something, you at least know the disease. And then what I do is if it's my patient, then what I'll do is I'll co-scrub with my colleague, for example. So I'll evaluate it together and then we'll co-scrub and then I'll kind of learn it. But yeah, so it does get so broad that it can sometimes be a little bit overwhelming, but it also keeps it exciting so that like, hey, you never get bored. You're like, okay, like at some point I want to focus more on pain interventions, but we'll be able to do that, you know, because we have that background and understanding of this process. Another question is, should we get wound care certified? And yes, I think so. I think we're seeing a lot more wounds, especially again, diabetic foot wounds are one of our residents is kind of wound certified already. And I think you can really, what I've recognized is patients may not even get, even if you open up the circulation, a few things that impede their wound healing. One is their diabetes is not well controlled. 2 is their nutrition's poor. 3 is there may be some underlying infection. 4, their wounds are not debrided adequately. Um, and 5 is you don't have adequate offloading, so you're repeating injury to the vessel. Okay. So I think those are kind of things. This is a really good question here. So let me answer this. Thanks for talking to us in IO, interventional oncology. Many of the procedures are targeting liver and kidney cancer. Is there a reason why interventional oncology is not expanded to the same extent to other organ systems? So yeah, that's a very good question. You're right. So one of the challenges of interventional oncology is it's primarily in the liver for primary cancer of the liver, which is hepatocellular carcinoma, which are about 17,000 cases per year. So it's primarily a transplant center. So in the community, you're not going to see as much interventional oncology because it's just not that common. Metastatic disease to the liver, the primary therapy is usually resection for colorectal for curative intent. Ablation's not been proven to be equivalent. Ablation's equivalent for hepatocellular carcinoma, primary liver tumor, but not for metastatic. Okay, so that's one thing. 2 is really the kidney. We have, not level 1 randomized comparative data for ablating small T1A, i.e. 4 centimeter or less tumors of the kidney yet, but we do see these in older patients, and it's a very nephron sparing thing. And at least the prospective and retrospective data we have is pretty good. There's also was some lung ablation going on for some time, but SBRT or radiation therapy is actually quite good for local control. So it's a combination of SBRT and kind of an ablation for lung. And then we do a decent amount for bone. If it can't be radiated, we'll do osseous ablation. And sometimes some centers like MCW with Sean Tutton are actually doing not only the ablative therapy, but also fusing. So I think there will be increasing role in certain types of tumors, such as desmoid, which I think some centers are doing more and more. But you're right, it's not going to be quite to the same extreme as the other things yet. But things are moving. For example, there's more and more thyroid nodule ablations occurring in Korea and Italy, and we're actually, and as well as at UVA, so a few centers here are doing it. There's devices that are now approved for thyroid ablation. So we're probably going to see more and more of these things occur, and even like low-grade breast lesions may be ablated with cryoablation, et cetera. So even though it's not ripe yet, it's an area of expansion that is occurring. But a great question. Which do you think the next vascular innovation IR? I mean, it's so hard to predict. I mean, there's so many. I mean, this endovascular AVF is really taking off, where you can percutaneously form fistulas. Like I said, thyroid ablation is another very exciting thing. the way we remove clot from the human body and the big veins is also changing pretty rapidly with some of the newer devices that are being developed. So these are all like kind of, I mean, there's so much possibility. It's hard to know where it's going to happen. Oh, so this is a question about advice on how to go about selecting an institution to complete away rotations during fourth year. That's a really good question. I think you'd base it on talking to other students. I would recommend. I think there's also, so I would kind of ask other fourth year medical students where have you rotated, where you can get a good hands-on experience, which is very busy, and seeing the scope and breadth of interventional is what I would recommend. So you want to be treated like an intern as much as possible. You want it to be very busy. You want to see everything you possibly can, and you know, potentially get a letter from that program. But that's what I would recommend. But it's a challenging thing to do, especially now, because I know with this whole COVID crisis, it's hard for the organization to open up to medical students right now. But yeah, I mean, and we could talk offline about that. You have my email here, so you can shoot me an email. I could talk to you on the phone about kind of how I would go about selecting some of that. All right, so in terms of evaluating training programs before applying at ERAS, how is an applicant able to evaluate how complete the service lines of the program are? For example, volumes for neuro procedures, and evaluate if they have admitting privileges and the extent of that. So this is really a big problem, right? We don't have very good transparency of what the different programs are offering or alluding to. The one thing you could do is, yeah, it's tricky. So it's something that I brought up multiple times at APDIR meetings. It's like, hey, the trainees don't have a real idea what's really going on. Those who rotate there can give you an idea of the scope and breadth and et cetera, and the culture and whatnot. And even like the autonomy that the trainees get is important. So if the fellow is not able to, you know, do a basic procedure because the attendings are doing everything primary, well, when are the trainees going to learn? So, you know, I've always been a big proponent of getting the trainees in early to get these skill sets so they can keep on getting better and better and building upon it. Whereas, you know, unfortunately, and I think this is a problem with the current IR residency model, they're not used to doing that, where you get the trainees in early and get them trained up so that by their 6th year, they're just kind of like really pretty advanced physician practitioners. But it is really good question, and there's not a lot of transparency about training programs and admitting privileges, neuro capability, et cetera. There is on the RFS website, and you can, again, email me and we could talk about it, but on the RFS website, we try to make some of it available, and we may need to consider Siddhant and Rehan, maybe we need to work on that again this year, updating it, but that's, again, a great question with not perfect answers. So this is a great question. Where do you see the future of pain intervention and interventional radiology? I think IR is going to have an increasing role in pain interventions. In fact, in our group, one of the most rapidly growing parts of our practice is the pain component, and especially from the oncologic population, from nerve blocks and whatnot. But it's a huge, huge population with that pain. Okay, so I do think there will be a growing role, and there already is a role, and there's going to be a growing role, especially in the community. So if you look at kind of from venous disease and oncology and pain, venous disease and pain far out trump oncology as far as volume in the general population. So just from a patient standpoint. Is there value in transitional year with lots of relevant electives, vascular, urology, hepatology, transplant, compared to full surgery internship? So that's, again, a very good question. The problem with that is, I think, you know, that'd be great, but the problem with that is you don't have a house, okay? So you're coming to one place, then you're going to another place, you're going to another place, without really anyone kind of overseeing you. Whereas if you're a surgical intern, you're kind of in that whole lump with the categoricals, and you're kind of part of that group. Or your medicine, you're still the same thing. You're kind of lumped in that, and you have like a family kind of thing. So you're treated more like, you're not quite treated like an equal always, but you're treated more like an equal. So when you're in a transitional, you're kind of, it's so variable how the transitional year is going to be. So in general, no. I mean, there are some transitions where you do a lot of ICU, do a lot of vascular surgery, you get a great experience, but the average one, no. You know, so again, it's always kind of local, but that's the one problem I see, is you don't have like a parent body that's kind of telling you, hey, you need to get this done or that done. You don't have like a categorical group. All right. how can we best ensure a patient get unbiased opinion of care? For example, one could imagine neurosurgeon trained in interventional neurology could perhaps best advise when endovascular coiling versus surgical clipping is indicated. Is there an IR equivalent? Do vascular surgeons IR normally evaluate a case together? That's again a wonderful question, right? Because there's always going to be bias, right? So my bias is less invasive is the way to go, almost always. But at the same time, you have to look at safety, efficacy, and durability. So what that entails is no matter what, if you're taking care of a disease, whether it be liver cancer, lung cancer, whatever it be, or aneurysm or whatever the disease process is, you have to be as unbiased as feasible and say you would be better served with a surgery than a minimally invasive or than a endovascular option or a ablation or what have your taste. And so the onus is on the individual. Even if you're a neurosurgeon who does neurointerventional, you may still have a neurointerventional bias or an open bias, you know? And it's hard to be good at, like, you know, the thing about an interventionalist or interventional cardiology or interventional radiology when they're doing, you know, kind of vascular conditions, that's all they do. So they're playing, they're not playing, but they're using catheters and wires and balloons, and they don't have an open option. So they're more likely to keep on going after it. You know, having said that, there's some very, very good vascular surgeons who are very, very, very capable, very competent, very skilled in endovascular procedures. So it's just kind of just a mindset though, because you're right, you're kind of almost a one-trick pony. So it makes you think purely interventional sometimes. But that is something that every interventionalist will face, you know? Let's see here. These are great questions. Are clinical practices solution to procedural turf wars? Yeah, so I mean, I don't know if I believe in the word turf, to be honest with you. I just think it's competition. So you have several people doing spine work, right? If you look at the number of people doing spine interventions, there's orthopedic surgery and neurosurgery both doing surgical spine work. There's anesthesia, PM&R, neuroradiologists, interventional radiologists, neurointerventional radiologists, all doing spine interventions. So I would just say there's multiple players in the field, but I don't think I wouldn't call it a turf. So yeah, if you can't see patients in the office and you can't do this, yeah, you probably shouldn't be offering that therapy, in my opinion. You know, you should be able to guide and counsel them, and that includes surgical kind of options and approaches. So there was a question about how many years do you recommend someone should practice IR before transitioning to innovation? Well, I would say you should be innovating even as a student or a resident, to be honest with you. So I don't think that, I think IR, even if you're not creative in nature, forces you to be creative, because you're asked to do stuff when no one else can figure out what to do, right? There's a problem. None of the kind of traditional, either proceduralists or surgeons or, you know, internists have an idea, or ER has an idea what to do and go, hey, can you figure out a solution for this? And that's when you will have to rise to the plate. So again, I think interventional breeds innovation in some ways because of that. And so I don't think there's a time frame where I would say you should start innovating. I think the innovation starts as a medical student and a resident. You should start offering ideas, go, hey, what if, or why not this, right? So you should always question, hey, why can't you do it this way? Or have you ever thought of this? Or hey, I've seen that done here, you know? And I think that's how we all learn and get better too. So you want to kind of question everything, you know, and go, hey, why not? Why can't we do it better? But these are awesome questions. Any more? Hello? Hello?
Sid? Yeah, we're still here.
Okay. Hey, any other questions?
Good to go. Let's see. I haven't gotten any recent texts. I think we were able to answer all of them.
Do you have any questions or?
Oh, I did get a new question. This is from Max Rayner. He said, a private practice IR not being able to admit and bring a patient to a hospital because a different DR radiology group has an exclusive contract. So he wanted to know your thoughts on that.
That's the 800-pound gorilla and the elephant in the room. Yeah, so I do think that is a big challenge that we're going to have to, as a society, overcome. That if you, as an interventional physician, want to practice kind of either independently or admit your patients and do the clinic, you should be allowed to do that. And these exclusive contracts, should not prevent someone, of doing the right thing. But it is a real issue, and it's something that we're going to have to address as a society, for sure. But very kind of thoughtful question that I don't have an answer for, unfortunately. But I do think it is I think it's real. I don't have a simple solution for that, but it is definitely something that we're going to have to overcome. There's another question here. In the event that aways are limited, what do you see as the biggest things for applicants to work on for the next few months? Oh, that's a really wonderful question too. So I would say, what are the things that you need to work on? Like step one's already over if you're third year. Try to do well in step two and study for that. So now's the time to kind of spend some time to do that, because you want to, if you, as soon as that's available, while this time is off, or whatever it is, study for that and try to get that done, right? And then I would, the things that you can do is get involved in, the Med Student Council or the reserves, and try to accomplish stuff. If you can develop an IR interest group, that's usually a big thing. If you can run a virtual symposium like this, or IR symposium or something, I know it's social distance is tricky, but some type of virtual symposium or something of that nature with your students, showcase attendance, and those are things that kind of go a big way. So kind of medical student recruitment and kind of being involved in the society. Again, it's very tough now because of this whole process, but usually when you go to, going to these kind of meetings, SIR, Midwestern Symposia, these kind of big kind of regional meetings, like a academic interventional radiology meeting, which is usually in DC area. I mean, those are the kind of the big meetings where you can kind of network and meet and talk to people and showcase your interest. Research that you present is also important, right? So going to, if you've got research or time now to do research, whether it be case reports or present, whatever it may be that you can accomplish in IR is also helpful. So those are things that I would do with your time, and just kind of learn more about IR, so you're knowledgeable about IR, read the kind of the books that are out there about IR, and kind of try to ask as many questions. I mean, being involved in this webinar is a good, start to kind of getting a foundation of what IR is about. But yeah, these are really good questions, I think. So for the younger ones in the crowd, how is the pass-fail step one going to change everything? Yeah, that's I don't know, but it is a problem in the sense that either, schools are, that places or program directors not as familiar with, may be impacted by that, because it was a way to kind of level the playing field a little bit, so to speak, So it will make things differently. Perhaps we'll have I'm just speculating here because we haven't had our APDR meeting. It comes in April. But what I'm thinking of, one option is to have a supplemental application, so we can identify further, like what ways have you done, what your kind of total IR involvement has been, you know what I mean? So things of that nature will be probably what we'll do. I mean, I think once you get there, we will have an idea, but just to get you in the door is going to be the tricky part, to identify, like, what you've done. So I think that fourth year showcasing, like, hey, I have real interest in IR. I've been shadowing IR. I've done IR research. I've seen all these kind of procedures. I've been to talk to these docs here. I've done this research. I've rotated here fourth year on these places. I've done summer research. Those all showcase interest in understanding what IR is about. I think that's going to be helpful. Why don't we talk offline about which books, because there's a lot of good books, but maybe you can shoot me an email, we could talk, and I'll kind of give you kind of my thoughts on the various different books, because there's several good books that are out there. Nikki Keefe's book is great. Shantanu's book is great. Warapandi's book is great. Justin Schaaf's is good. So there's a lot of great books out there. There's a handbook, there's requisites, there's a lot of good books, but we could talk about and go over the pros and cons of each one kind of individually. Yeah, great. Any other? Okay, here, one more here. If one is interested in interventional neuroradiology, is there merit to pursuing that path by IR as opposed to DR? neuroradiology. So that's a great question. So in our program, what we've done is we've incorporated like 3 months of neuro-IR and then the neurostroke. So they'll, by their 6th year, they'll have so much neuro training and they could do more neuro ICU. So I personally think that it makes more sense to do it through the IR pathway, because you'll get a lot of peripheral experience and knowledge. And then you'll also be able to, if you go to a place that does neuro-IR already, you'll be able to do more neuro-IR during those IR years and maybe neuro ICU. So during those 6 years, you're gonna get so much neuro training that you'll already be pretty good by the end of a busy busy IR residency. And then you add upon that those, neurointerventional, and you'll be coming out very skilled, exceedingly skilled. So I personally would think that an neuro-IR path would make more sense from a training standpoint and skill set acquisition and clinical acumen and knowledge base. All right, so another question here. How do you envision expanding scope of practice such as into pain or peripheral arterioles management among others you mentioned with such a significant difference in the current practice IR from facility to facility? Yeah, so I mean, I think one is you try to go get trained in it, right? And then 2 is you have to learn it undifferentiated, like if you're doing pain, like a pain specialist, kind of how to evaluate a patient's pain, identify the pain generators, how to treat them kind of pharmacologically, and then how to treat them with conservative measures, and then with blocks or rhizotomies or spinal cord stims or pain pumps. And then from a PAD standpoint, I think it's going to be important to just, again, understand the milieu of diseases that cause it, diabetes, hypertension, and understand the management of that, understanding how to manage a diabetic foot wound, learning kind of examination of loss of protective sensation, how to offload properly, whether it be a wheelchair or scooter or crutches, whatever it may be, managing the kind of infection, and then the revascularization, which is kind of in your technical skill set. Control. So I think if it's not, it's very doable. And I've seen many interventionalists who've come out after training who've been able to pick it up pretty quickly. But you would ideally go to a training program that will give you that skill set, because it's an obstructive skill set, whereas oncology is more healthier vessels. In the coronaries and the PAD patients, they have more diseased vasculature. But it is a problem that there's such differences in IR from place to place. But that's why every IR division should really focus on building all aspects of the training, right? So, or send you out to get that training. And that's what happens in kind of DR, right? If you don't have a peds hospital, you go to a pediatric center and get trained in it. So there should be no difference here. So I think as time goes on, you need to, as students, you need to demand that training, You need to go like, I need to get this training. And so that was one of my goals, is like, hey, even though I don't personally do pain right now, I wanted to hire someone to build a pain division. So I knew that was going to be important for future trainees. Other questions? Hello? Sid, or?
You cut out there for a minute, but you're back now.
Can you guys hear me?
Yes.
Oh, what part did I get out on? Do you remember?
I was able to hear you for the most part.
Okay. Any other questions?
Yep. Dr. V, I guess I had one question which just came up. How much of the residency program really falls, like the responsibility of training falls on the program itself, versus how much independence do residents have or students have in terms of demanding the type of training they want, or how much can they, be an active role in the training they receive?
Again, I think that's a solid question. So certainly when I trained in conventional diagnostic area, but I asked to rotate in kind of clinic, vascular surgery clinic, and do additional months of IR, neuro-IR, et cetera. So I think you have a lot of chance to change, be the voice of change and push for it. And I've seen many programs after talking to them like, hey, you should institute this and this. Some have not been able to do it, but many have. So I think you just have to keep on, be a good resident, come in, feel a first in, last out, do well on your diagnostic rotations, read a high volume, do well on your exams in the diagnostic years, and then go ask for more time on IR and ask to do clinical rotations, and ask if you can adjust the blocks. Is it going to happen everywhere? No, but is it going to happen somewhere? Yes. And so the only way you're going to find out is by asking. So yeah, not every program is going to have it, but you have to be the voice of change. And we'll certainly, and I'll certainly guide you and help you to kind of get those things accomplished, or at least try.
Awesome, thank you. Any other questions from anyone? If not, Dr. V, I guess I know for a fact I'm speaking from all the people who have attended today. Thank you so much for taking the time and making this happen. And again, I'd like to echo that thanks to as well from my end to everyone else for attending and making this such a success. I had a great time, and I obviously learned a lot, and I know everyone here did as well.
All right, thank you. Thanks for inviting me.
Thank you so much. All right, guys. Well, this is the end of our first MSc Reserves webinar. Big thanks again to Dr. V. If you had any suggestions or comments or anything else I could follow up on, or if hopefully we do this again in the future, if there's things that we can do better in the process, please shoot out those emails or text to me, and we'll keep going at it. Thank you, everyone.
And yeah, you have my email, so please feel free to reach out to me, and I'll try to talk to you offline about any of these issues or others, or kind of teach you more about the field, or help you with your whatever your local concerns are, and kind of individualize the discussion.
All right, thank you so much, Dr. V.
Awesome. Have a good night, guys.
Take care.
Thank you. Take care.
Sihan, if you can stop that recording there.
Yeah, doing that.